I put up the word power. So when you think about what it takes, or when people talk to you about what it takes to battle a serious illness like breast cancer, how many people are telling you that you have to pull from your inner strength or power? How many people have heard of that? Yeah. And with that power, that means that you're supposed to be resilient and strong, right? Yeah, that's all you have to do. And you're supposed to pull that power and resilience from inside of yourself, in addition to going to chemotherapy. But when we take a look at what it takes to be resilient, it takes support, it takes development of meaning and purpose, and many of the things that requires resilience comes from outside, right? So when they tell you that you need to be powerful and resilient, in order to be powerful, in order to be resilient, you actually need other support and other help. So when we talk about palliative care, I just always like to say we probably need to have a common language. So palliative care is the medical specialty that focuses on people living with serious illness. It focuses on providing relief from symptoms and stress of serious illness, wherever you are in the diagnosis. And the goal is to improve quality of life for both patient and family. Palliative care is provided by a team of doctors, nurses, and specialists who work together with other doctors to provide an extra layer of support. It's appropriate at any stage of the illness and can be provided with curative therapy. What in that definition is not there? Say it loud. Hospice isn't in that definition. What else isn't in that definition? Right. And the reason why I bring up and point out these words, because it's really important to understand when we talk about palliative care what we're talking about, because it can be hard. If you Google palliative care, what comes up? Like every hospice, in Google, 40 hospice Google ads, and then you finally get down to what this is. So, when you're going through something stressful and your doctor mentions palliative care, that can bring up a lot of feelings and emotions and also be a barrier for people to feel comfortable seeing us. But before, we're going to have this presentation, but I really want to get to what the punchline is, and the bottom line of what I want you to know is palliative care is not here to help you die. It's here to help you live. It's not just to help you survive, right? Because you can survive on your own. It's to help you figure out a way to thrive. The care is not here to help you be resilient, not here to help you be strong, but it's really to help you be the person you are at that time. And palliative care is not there to direct your decisions or decide for you. It's here to make sure that you're informed, that we're honest, that you have the support. And number one, no matter what decisions you make, we have to accept them. Anybody in this room ever struggle with the idea in conflict with your healthcare team in accepting the choices you made? Mm-hmm. Yeah. And how difficult is that? How difficult is that when you're working with people that you trust and then there's conflict and you feel like maybe you all are on the same page? Right. Part of what we do, in addition to support, is we serve as a bridge between you and your team to come to a common understanding. Because what I say, you speak people, and I speak people, but your oncologist team, they speak doctor, and I speak doctor. So sometimes all your team is really doing is taking what you're saying and present it in the way in which they can hear it. I say like a human translator. like Google. I'm like a Google translator. Because when you look at this picture, this is one of our famous palliative care pictures, that when you develop a serious illness, everything is coming at you at once, right? It's like the moment you hear it, we're running out of the gate. And time, pressure, you have to make decisions on a dime. Well, really, you're not making decisions. You're doing what we asked you to do. And it can be really overwhelming. And even with all of that care, even with all that time and attention that your wonderful teams are giving you, do things sometimes fall through the cracks? Yeah, they fall through the cracks. Because people can't be everything to everyone. So when you think about who we are, when this was originally made, we were supposed to be the support under the bridge. But doing this for a long time, I am the support under the bridge, but I'm kind of the mortar in between, right? Because you can even find support under your bridge, but what you need is people to catch things that slip through the cracks. Because what does illness actually threaten? Certainty, your security, your confidence, stability, and well-being. All of those things that make it so that you move through life, and all the things that make you who you are, when you get a serious illness, all of those things become threatened, and we start to question. Does that sound about accurate? Yeah. So when you go and you see a palliative care team, so what are we offering? Well, we're offering the 3 H's. And I say we're like the Good Samaritans of healthcare. We can't fix that the bad thing happened. We can't fix that the bad thing happened. We can't prevent, but what we do is take care of you and the time and where you are. So we're offering helping to achieve whatever your goals are. We're offering hope. Right? So how often do you hear palliative care and hope together? Probably not often, but the truth is, we are here for what you're hoping for. When we ask that question, and if you visit one of my colleagues will ask what you're hoping for, is because we really want to know, and oftentimes we're hoping for what you're hoping for. And then if what you're hoping for is not possible, then we're here while you start to reframe. We also offer holistic care, right? Because when you get an illness, what happens to your identity? It changes, right? It changes, yeah. Yeah, it changes. You're walking around your friends, that's Sally, she has the breast cancer. I don't know why I'm whispering. It's almost like it starts to lead and precede everything. And that's really, really difficult. And then people start to change their behavior, and everything sort of revolves around that. I work at Emory, and we say, Emory's your family. And I laugh at my patients all the time. I'm like, yeah, we're family. We're all up in your business at all times. And I said, we're more like a wife or a jealous boyfriend. We want your time all the time when we want it. And they usually laugh, but that's kind of true. And so the part of you that needs to be cared for, we're focused specifically on what's happening to you physically. But as you said, your life goes on. Doesn't life go on? Yeah. So it's holistic. And that's what we focus on. And our philosophy is that you set the agenda. And we serve as guides. So I tell people, I'm always going to be honest. And I will tell you what I think. I will give a recommendation, but once you have told me what it is, then that's what we're doing. And we help you also work through uncertainty and actually acknowledge that uncertainty exists. So where do we fit in the medical system? We often fit in the medical system where evidence-based medicine fails. Right? Have you ever come with a symptom or a complaint to your doctor, And they go, the medication doesn't cause that. I'm like, no, I don't think that shouldn't be causing pain. Should it? Well, unfortunately, you forgot to read the book and the package insert that told you that you were not supposed to get a rash. But yeah. So we work with, and evidence-based medicine fails, and we figure out where you are. So as the kids say, or as my little guy over there would say, Mom, you got to get in where you fit in. So when we think about palliative and supportive care, so what do the organizations say? Well, ASCO, which is the big oncology conference, and what ASCO is, if you guys aren't familiar with ASCO, is there a time of year where it seems like you can't get a hold of your oncologist and they're all gone? They're at ASCO, they're in Chicago. So in June, save your questions. On June 3rd, nobody's answering. They're all at ASCO, but the ASCO guidelines say that if you have advanced cancer, that access to interprofessional palliative care is standard, right? And we're all about standard of care. And when we think in palliative care and supportive care is not equal to hospice. But hospice is a type of palliative care. So what I explain to people is that palliative care is like an umbrella, right? It's a philosophy. And depending on where you are in your illness, you will get it delivered in different ways. So if you're coming back and forth to the clinic and things are going really well, then you'll see me in the clinic. If you live really rural and you can only get back and forth to your appointments and you're really sick, we're probably not going to drag you to a palliative care clinic. We're probably going to provide it in your home, and you're still going to get your treatment. When the time comes where the treatment is taking away more than it's giving, right, then at that moment, we deliver palliative care through hospice care. So I also want to talk to you guys a little bit about all the things that you should have as well. So how many of you guys heard of supportive oncology? Yeah. What is supportive oncology? Well, depending on where you are, it means different things to different people. So I impart palliative care and supportive care is one slice of the pie. But supportive oncology are all those other services that make it that makes your journey easier, that helps to take care of you as a whole person. Because even palliative care, we have our limits. So financial, nutrition, cancer rehab, psychological support, all of the part of the wheel should be available to you when you need them. So I want to talk a little bit about hospice, because I do take care of people. I take care of people at the beginning of their journey, and I take care of people who are coming to the end of their journey. And when we think about hospice care, it invokes a lot of emotions, but actually all it is an insurance benefit. It's an insurance benefit. It is the way in which we deliver care to people when they need a lot of it, when the treatment that we were normally given is no longer working, because if it was working, you wouldn't need it. And it provides the most comprehensive support for you that you and your family need. And I don't want to, and when I say that to patients, because there's just a practical side, and there's also a philosophical and emotional side, right? If I told you, hey, I got this thing, they're going to pay for all your medicines, give you whatever equipment you need, take care of your family, and let you do what you want to do, yeah, you can eat cake. People are like, yes, I want that. I want that. I even have a volunteer. Somebody just mowed my lawn. It's amazing. But if you say hospice, people are like, no, right? So the word, so when we think about it, or if you're, and sometimes I see people in groups or even other patients and other people when they're talking with each other about, hospice or palliative care, and the person or their friend beside them is not so sure or frustrated, is because we have to remind ourselves that even though something's great, it does come with a realization of where things are, okay? So hospice is only helpful if you are ready for it. So where can you get our services, right? So where should you find palliative care? So primary palliative care. How many of you have an excellent oncology team? How that team is on it, right? They take care of you. You know, how many have oncologists or advanced practice providers who really listen, where you feel connected? Yeah. Social workers that are all up in it, filling out forms, getting things together. Yeah. So what they're actually giving you is primary palliative care. They don't name it as palliative care. Well, we don't tell them, but we know that's what it is. But that's what they're giving you. So if you are in a team and it's working well and all your needs are met, then you are actually getting the standard of care. It's delivered by your primary team. However, when things get more difficult, maybe you're working with a team that's under-resourced, right? You know, people and doctors move across the country. Healthcare is in a financial crisis, so maybe the services get a little thin. You're calling and, you know, they used to answer your question in like an hour, and now they haven't returned your message like in 2 days. When you start to see that, and you see that not all your needs are getting met, that's when they may call in specialty palliative care. That's when you're getting access to an extra interprofessional team that's going to shore up your oncology team and keep the wheels on the bus. If you're not feeling well in the hospital, and this is where most people meet us, hospital consultation is provided. And so when you think about palliative care in the hospital, people mostly think about goals of care and things are not going well. However, most of my patients who go in the hospital, things are going just fine. You know, they just got COVID or they have pain. Everything would be great if we can manage their symptoms. So consultation, and if you're in the hospital and you're not feeling well, things aren't going well, your symptoms are not well controlled, then you're not going to be well enough to achieve your goals, then getting a consult of palliative care there is really important as well. And then home-based and supportive care, home-based palliative care, actually comes out to your home or when people are in facilities. They both come with interprofessional teams. So when you go to palliative care and you just see me, you didn't get the interprofessional team, right? Because what we told you is that we were going to take care of you physically, spiritually, and emotionally. And that's not something one discipline can do. So that's the importance of a team. And if you have palliative care where you are and you don't have a team, you don't have the standard of palliative care. So what can you expect when you come to a visit with us? Okay. Besides lots of hugs and feeling questions. So if you come to a visit with us, you know, you get your symptoms managed. We do talk about goals, short-term goals, long-term goals. One of our favorite questions is, what do you want to do? What would you like? If you felt better, what would you be doing right now? And that's sometimes how we set, you know, what we do and how we deliver care. There's resources that we give to the community. In my particular clinic, we offer counseling for children and for family members. Like whoever's taking care of you gets access to all of our services. And we do advanced care planning. And when I talk about advanced care planning, it's not just advanced directives and living well. Like advanced care planning is like, hey, can you afford any of this? If you go to a period where you can't take care of yourself, who's going to do that? Can you take off work? Have you applied for disability? Regular FMLA, intermittent FMLA, right? Do you have lights? Like how is all this working in transportation? So not only figuring out, because there's a lot of things that happen between getting diagnosed, at the end of the journey, there's all this stuff in the middle that people need help with. And I always say that If you want to do something very aggressive and very hard, then we need to give you the best chance possible, and you need to feel as good as you can feel, and you need to have all the other social things tucked in as well as we can to actually give you a shot, because it's not really fair to say, hey, we have all this fancy stuff and you can't have it because you feel too sick or you don't have the resources to get it. So this brings me to something called advocacy. So I'm so glad I'm here at your conference and you all are great advocates. So now I'm going to do my little pitch. So we're doing better, right? You know, about 83% of US hospitals with greater than 50 beds have palliative care teams on the inpatient side. And so, and 83% isn't bad unless you live in the South, it's rural, you go to a safety net, you go to a public hospital or a hospital that's for profit. Other than that, we're doing fine. And I'd like you to look here. When you think about palliative care and how we're doing, all the regions in the north, on the West Coast, they were doing pretty good and they just got a little better. But when you come to my side, down south, we were doing kind of bad, and we're not lousy, now we're just terrible. So there's a wide disparity. So why I'm here with you now, and this is amazing, there's so many women who don't have access. There are actually deserts across the country. And if you look at the D and the F, you can see that, hey, they grade it like A, B, C, D, like A, if you have palliative care, you're super awesome, like if you're in Massachusetts, yay. Let nothing ever happen to Massachusetts, that is where our brain is. So but when you look at the D's and the F's, there's not much movement there, right? So that just means as we get better, the disparity is widening. So what is the barriers? Why are they there? So still a lot of misconceptions. You know, in my part of the country, this can be a little difficult. People still believe, I have oncologists still believe and say, I'm going to call palliative care. But no, Kimberly, they're not dying. I'm like, I know. You know, but they're still worried about it. Lack of financial support, right? Because when you have a palliative care and an interprofessional team, what does insurance pay for? It doesn't pay for the spiritual health clinician, often doesn't pay for the social worker. So the mandate is to have a team, and ASCO says you need a team, and CMS thinks it's great to have a team, but nobody's paying for the team. Right. So, you know, when you think about, you hear, like, I don't know if they ever send you, like, bills to support or lobby day, and it's like all this want. You know, a lot of getting involved on a national level and supporting other people who are trying to get interprofessional teams paid for is really, really important. And we can say it all day long, but what they really need is to hear from you, that this is important, this is part of your care, and this is what you demand. There's also a lack of trained providers, right? This is a profession. I've been doing this for 20 years, and I still learn things every day. So you know you can't take a course online and do this job because you could cause harm. Other referral barriers can be bias. If you put palliative care and African Americans, what you'll get is 45 articles that say African Americans aren't open to hospice or palliative care and want aggressive things at the end of life. So that's what's taught in the medical schools. That's what people are ingrained with. So if you're a brown or black woman and you go, doctor may be a little cautious about talking to you. So you don't even know your options because they already have decided you're not going to take it, right? So I want to ask people to raise their hands, but have you ever felt like you weren't really getting all of your options? that they weren't really talking to you, right? Or they're talking to you, but they're looking over there. Yeah. White coats are not magical, right? As close as you feel to your oncologist, that's how close they feel to you. Even the most stern ones, hard shell, but very soft on the inside. I've met very, very few that didn't really, really love their patients and care about their patients. So and it's very difficult to admit that when you go to medical school, what do we go to medical school for? To help people. We feel like we can talk to people. So how hard is it to ask somebody else to give you what they're not able to give you? And then you come in, oh, Dr. Curseen was so wonderful. She was amazing. Where has she been all my life? They're like, yeah, well, whatever. Okay, fine. I've been taking care of you for 20 years, and here this girl comes in, and she's everything to you. So, we think about those things. We have those things. You have no evidence of disease, so you don't need palliative care, right? So this brings me to my little detour, and because I have you captive, I'm going to stand on my soapbox. This is not in the literature, this is in Kimberly's brain. No evidence of disease should be replaced with no current cancer found. If you have cancer, and maybe they don't see it on the scans anymore, there is evidence of disease all over your body. If you have had a mastectomy, there's evidence of disease. If you have chemotherapy, you look at your nails and your hair and your skin, there is evidence of disease. That is insane. Thank you. Thank you. And when you look at people, or I love it, no, the disease is stable. Yeah, so it's still there. So when you look at this study that shows looking at people who have been living with breast cancer for like 7 years, a good portion of them complain of pain. Right. So when you walk in and you say, I have pain, you're not drug seeking. Because the moment you say you have pain, don't we start sweating? Well, okay, the visit wraps up really fast. Well, I'll just go ahead and send you to somebody. No, you really, really have pain. And we need to be in a place to be able to treat it. Yes, you still have fatigue. I'm sorry, yeah, you stopped chemo a while ago. Yeah, you're still tired. All of those things. And there are physiologic reasons why those happen. And we need to, as palliative care providers, whether we're giving specialty or primary palliative care, be willing to treat those symptoms as real and not imaginary. Another thing on my soapbox, cure of no evidence of disease does not equal wellness, right? In our institution, people ring a bell. Yay, ring the bell. And what they fail to tell you is that, we're all excited about the treatment and things are going really, really well. And then all the support and everything kind of disappears. You're just seeing your oncologist every 3 months, you're getting scans. But you still don't feel well, right? Because there's a whole other mountain that you have to climb in order to get to any place called wellness. And there's all this grief and loss, all this trauma. Yeah, what you guys have experienced is a trauma that you are now have the time to reconcile. So this is not the time where your team should be leaning out like, yay, good luck to you. This is the time right after is where everybody really needs to lean in. This is where you need your friends. This is where you need your significant others to understand that as tough as that was, you have another tough thing coming. And the better you look, because everybody goes, oh, but you look so good. I'm like, I know, but I feel terrible. I don't know, I guess I expect you guys just to walk around in sackcloth with a sign saying, I feel bad today. No. But we need to be able to remember this, and I think that we don't pay enough attention to this part, because this part, when we don't do it right, you are now surviving, but you're not going to thrive. So my eyes are really, really bad, and I can't see that screen. So I'm just gonna go for it. But access to high quality and palliative care is not something that is a bonus, right? This is an expectation, and access to palliative care with an interprofessional team, not just Kimberly, making stuff up, going to the Google to look for resources. You need an interprofessional team. That is the standard. Asking for palliative care is not giving up. The truth is, people can't actually give up. Like, you all can say, I give up now, and you're still going to be here. It doesn't work like that. You're not giving up. What you're asking for is the support you need to be able to go through your journey. So the words that you need to tell doctor people when they say, oh, I don't think you need palliative care, you have to, palliate us and hold our hands and say, no, I'm down for this treatment, but I will not make it through this treatment if I do not have some help. And you only got a 15-minute appointment. You cannot help me. In a sweet, loving way. But you all know your doctors, the words to make them hear you. Again, no evidence of disease. When you are going to cancer survivorship, they need to treat it with a palliative approach because you're not well. So giving you a treatment summary is not helping you with survivorship. It just isn't. That's not helpful. That's just a summary of everything that happened to you and be on your way. The survivorship really needs to be an interprofessional clinic. If you have no evidence of disease for a long time and things are going well, you still need that kind of assistance. And your organization should fight as hard for your quality of life as much as they do for treatment and cure. Because other than that, what is the point? Thank you, baby. You're increasing me. So in summary, supportive care is just part of the larger whole. Like, we're just a slice. So next year, when you think of all the people, cancer pain, cancer rehab, all of those people there, I would love to make sure that at some point you hear from all of my friends. I call them my friends and family, and how we work together to support you. People living with serious illness, you are not the illness, you are a person, right? And the care that you get has to be congruent with your values. And sometimes we may not agree with those values, but if we're going to be in your care and in your presence, then we need to support those values. Okay. Hospice is a medical service. I know it's hard and that word is really loaded, but practically, when you need it, it's not just for you, but for your family, because that kind of support, it takes a lot. And the goal is for this to be a time that, as difficult as it is, not to be as traumatic, if that makes sense, right? To allow you, again, to thrive even at that part of the journey. And then, again, as I say, supportive care is provided by a team, and you all deserve a team. So I just want to say thank you. Yeah. I do have two resources there, getpalliativecare.org and palliativedoctors.org. And I have QR codes taught to me by my nephews. Because he's like, Kim, nobody goes to websites anymore, Auntie. I was like, oh. So the QR codes are there, but those are really great resources, and they are people-facing. They are written in English, and they are up to date, and they can actually and they both have doctor finders. So with that, I will stop.
Thank you, Dr. Curseen.
You're welcome.
Treating what your cancer is doing to you is my takeaway. What a profound statement, and thank you for, drawing our awareness to that. I have some questions from our audience that hopefully you'll be able to answer. As somebody who spends a lot of time in the medical system, one of the questions that just came across is, why is it always the patient who why is it always on the patient to get the standard of care?
That's a good question. Why is it on you? It should not be on you. But the healthcare system in this country, we have the best of everything, and we have all the stuff. What we lack is the ability to put it together, the logistics, right? And many people who are in higher positions are often like doctors and things like that. And it takes a way of looking at your care as the most important thing, which is not efficiency, but how we take care of you as a whole person. And our healthcare system is focused on efficiency. It's focused on cost. And it doesn't mean that it doesn't care about you. Everybody does care. But it causes us then not to integrate the way we should. So part of the things that we should be advocating for is not more stuff. We got all the stuff. What we need to advocate for is for our insurance companies, Medicare, Medicaid, to figure out how do you take that and put that together, getting the experts in the room. And you know who the experts in the room are putting stuff together? You all. You all know how the care should go. And who do we not ask? We don't ask you, right? You could solve half of our problems. So I think that we're seeing more and more, particularly like managed care, like Kaiser and things like that, having patients and stakeholders to help guide some of the decisions that they're making. So I encourage you, if you have the energy and have the time, volunteer, be a PFA, let your voice be heard. I know there are a lot of smart people, but they're not smarter than you.
Thank you. One of the questions that came in, which may be in your purview, is discussing the benefits of medical marijuana and tips on how to get that conversation started with your oncologist and physician.
Funny you should say. After the, I do a lot of talking about medical marijuana. That's my next talk. So this is tricky. Marijuana is still federally illegal. So the states that have legalized it, doctors can't prescribe it because it remains federally legal. In medical school, at least, probably not even now, they don't learn a lot about marijuana. So when you ask a doctor something they don't know about, have you ever brought a study and you know we haven't seen it, and we try to cover, and they were like, no, you don't need that, and then a week later we're like, hey, let me show you this new thing that I just found. We don't know. We have a lack of education. Also, you have to understand that your doctors are people too. So if it's not within their moral value system or structure, because when we think about marijuana, psychedelics, ketamine, assisted therapies, it's not only a question of healthcare, it's a question of morality, and it's a question of knowledge. So if you're thinking about, but why you have to talk about medical cannabis with your providers is because medical cannabis is like a drug like anything else. And it has side effects. And more information is coming about its use in immunotherapies. So they have to know what you're taking. So getting the conversation started is and number one, come and educate it. Number two, and saying, doctor, I'm not asking you to prescribe this, but what I'm saying is that I believe that this will help me with my symptoms. And they'll go, no, I don't do it. And say, I know you don't do it. So I would like you to refer me to somebody who does. Or I'm seeing this person, or coming to your pharmacist and saying, this is what I am using to get the consultation. So I hope that helps. But some will just shut you down, and it's probably for those reasons.
Thank you. Stephanie, I'll go to you. Do you have some question for us?
I do, thank you. Somebody asked, what are some of the newest innovations in palliative care to deal with pain from bone meds?
I wish we had more newer interventions, because you see the steroids and the radiation and opioids. So those, we haven't been able to move far beyond those. I have patients who now will use things like medical cannabis to help with pain if they are responsive, but it's also going to need a multimodal approach. You know, there are people who will offer things helpful for pain, but not all the complementary therapies have significant evidence. Acupuncture can be helpful, but when you have a bone met, the problem with the bone met is that it's causing a lot of swelling against something that's very tight. So I think adding all the complementary therapies in, but you're still going to need something traditional, anti-inflammatory, radiation if you can. Oh, cryotherapy. Have you guys heard of cryotherapy? Mm-hmm. Like they freeze it in a little ball. It's like really cool. And then sometimes it's going to require opioid management because it hurts.
Thank you.
An interesting question that's come a couple of times is about the language around palliative and supportive care. And one of our members here said that one of their institutions changed the name from palliative to supportive, and your slide indicated that these are palliative is part of supportive care. Thoughts on
the name?
Yeah.
I think the name, in our world, like there's a big, like we're all upset and we're fighting all the time about the name. But the truth is that we need you all to feel comfortable, right? And if the majority of the patients and the majority of the people feel like when they go to palliative care, it's frightening, then why am I going to keep that name? I'm still a palliative care doctor. Nothing changed about what I'm doing. But what you're also telling me is that's not something that makes you comfortable. So why would I keep it, right? I also think that, in truth, when you looked at our definition didn't say to palliate you, like, hi, I'm here to palliate you now. No, the definition said I'm here to support you. So I'm a palliative care doctor that's providing support. I'm your primary care doctor that's providing support. I'm your advanced practice provider, your social worker, your nutrition, providing support, because that's actually what we're doing. But I also think that the oncologist teams, and they were struggling, and I think they were struggling because they just found it too close to hospice. And also the word palliative means to cloak, to cover. And I do cover you in some ways, but you know, we don't want to hide you under, under a shroud and make this a secret, right? It's not a secret. You know, we need to celebrate you as you are. This is happening. You're here. You're people. So I think I'd rather lift you up than to cover you.
Thank you. From all of us. How is death with dignity being incorporated in palliative care in those states where it is legal? The process can be difficult and patients could use help for those who want the option?
Yeah, and that's an excellent question. And again, we struggle with this in our society because just the states have different laws. So I'm in Georgia, where it's not acceptable. Vermont, New Jersey. So number one, if you're considering medical aid in dying, and that's what we call it, then the first thing is to research your state laws. Then you have to establish with a doctor or provider. And that can be difficult because that ends up on you to do that. So that's when it makes sense to go to palliativecare.org. Entering into hospice care at that time can be really helpful, or asking one of the hospice agencies who would be good to help me through this process. And they'll talk to you about it, right? Because they're going to be the people that's going to be supporting you through it. And you want to make sure that you have a team that understands. Us doing this state by state, just like the way we're doing marijuana, is problematic because it doesn't mean that there's standards of care. So really, it's like each individual flower. So I wish I had a better answer for you, but number one, research the laws, finding a provider, and also making sure that if you're going to go to a different state, that you have the financial and the support, and trying to figure out what happens if things don't go as expected.
Thank you. Stephanie, questions?
Yes, we've had another bone mets related question. Somebody asked, what are your thoughts or understanding of oncology massage therapists for bone mets versus a regular massage therapist?
You want an oncology massage therapist because they have extra training. And the problem is that if you go and they hurt you, then you're worse off than you are before. Massage therapy for bone mets is complicated because when you have bones hurting, then all the muscles tense. So what they're able to do is work on the muscle. However, those muscles are fragile. And so depending on how fragile, where the bone met is and how fragile it is, a person who's trained in oncology massage will only take you if they feel like they can be helpful and not cause a possible fracture. Yeah, so that's why they just have extra training. So we always send everyone to oncology trained massage therapists. And I'm really a big advocate for oncology physical therapists. If you have access to it, it is a different kind of therapy. It's about it.
Thank you.
Have there been strides made to provide at-home health care employees during post-surgical or end-of-life care? Do you know? Sorry. Have there been strides made to provide at-home health care employees during post-surgical or end-of-life care? And then presently, hospice only covers a few hours per week and patients must pay.
Okay.
Yes.
So this is another hard part, another flaw. Again, we love living in our country because we have all this stuff. But again, when the hospice benefit was designed, it was designed, still at a time where us ladies were primarily at home, right? And people didn't move about the country as much. So that support that hospice was going to give, all the other family and church family were going to kind of pitch in to make this work. And the hospice benefit was really designed and thought of by people who had money and people of the majority. It didn't account for or sort of think about what happens if you don't have the resources. So in most states, if you have Medicaid, then they have programs that will pay family members to take care of you or allow having nurses for hours. And oftentimes, way back when my hair was still dark, there was a conflict where they would take the 8 hours away and if you had hospice. But most people, most states have fixed that now. Now, insurance, if you're over the age of 65, Medicare, woo, you have one of those Advantage programs, you know, things to be, Tom Selleck sells annuities. But anyway, but if you have one of those Medicare Advantage programs, many of them will sometimes have in-home care aides attached to those. But if you don't have Medicare, and you don't have Medicaid, and you can't access your long-term care insurance, then a lot of that comes out of your pocket. And that's the hard part. It's the people in the middle. So if you don't have any money and you have lots of money, you can get some help. But in the middle, it's really, really rough. And I don't think we talk about that enough. I don't think we talk about the financial toxicity of what this does to people. But it will require like an army.
This question is about dental care needs.
Yes.
Yeah, right, a great question. Are there any resources for dental care needs? One of our attendees has tried researching and has not found any resources. So is that something you can speak to and be helpful for?
I can speak to it. I wish I could be helpful. I feel like I'm just going to make you guys sad.
Oh, no.
Okay, so dental care. So when they talk to you about getting your chemotherapy, does anybody talk about dental care?
No.
They say they did, but they moved past it. But it's a huge thing. Everything gives you dry mouth. And the worst thing in the world is to get through something really hard and then have your teeth crumble. And then you call a dentist and they're like, no, we don't do that. So if you are connected to a university that has a dental school, if you happen to be getting care there, then you probably will have access because there'll be specialists there. Oftentimes, the American Dental Association, the ADA, when you go to their websites, will be able to direct you. The problem with dentistry is that they have lobbied heavily to stay out of insurance programs. Right? They have lobbied heavily to remain private care pay. So even if you can find somebody that often requires resources, or now you can actually take out a loan and make payments. So I think that if you can find, starting with the ADA, getting word of mouth, oftentimes your oncologist might have people that they send to, but that can be really, really difficult. So yet another thing to advocate for, like I would love to see if you have cancer, for then dental care to be paid for even in a rebate, because it's part of your whole care.
Dr. Curseen, you said in your presentation that as you know, someone with MBC, we are not the illness.
No.
And can you speak more about what you say to patients to encourage them to think of themselves not as the illness?
I think it all depends on what they're saying at the time. Oftentimes I'll hear a lot of self-blame, like, I failed the chemo, or I couldn't tolerate the tamoxifen. I just couldn't do it. A lot of guilt. And what I'd like to do is, number one, name that feeling, because that's how you feel. Right? Whenever has you said something and somebody goes, oh, there, don't think that way. Has that ever helped? No, absolutely not. So the first thing, so I don't deny that the feeling is there. I acknowledge the feeling and say it's very normal. But what I also say is, as an outsider, the person that's sitting in front of me is the only person that I know. And I like this person. And then I list all the things that I like. And, so I know you feel that way, but this is what we see. And all those people who love you, that really, really love you, this is what they see. Right? to try to help reframe, because we always look at ourselves with such a critical, harsh eye. We see all the flaws, but the people who really love us see the beauty, and the things you think matter don't actually really matter, because that's not why they loved you in the first place, right? If what you could do, or what you could offer, and how much you produced, and how beautiful you were, was the most important thing, then we would have no nursing homes, right? We wouldn't. Think about the person you love most in your life. If they lost all their hair, would you care? What matters is that they are present in the world, and you will often take them however you can get them. And the people who really love you is how they feel about you. And for my patients, that's how I feel about them.
Great. Yeah, go ahead, Stephanie.
Speaking of the people who care a lot about the people in the room with us, could you speak a bit about caregivers and how or if there's a role or a place for caregiver support within palliative care?
Yes, that is a large part of what we do. A large part, providing support for the caregiver. Because especially like if your caregiver is your spouse, your significant other, if your caregiver is your child or somebody related to your sister or brother, whatever's happening to you is happening to them too. You're not experiencing it the same way. Whatever decision you make, they're right there with you, and guess what? They don't get to decide or agree, right? They just have to go with it. And then everything revolves around the person who needs the most help, the person with the illness. And sometimes it doesn't leave a lot of room for the caregiver to even say anything, even if you would be receptive, because in their minds, they start deferring their needs, deferring their needs, deferring their needs. And then that relationship that was close and intimate starts to separate and become almost a medical one. And then the relationships start to deteriorate. So I think that when any couple, however the couple is made, however the caregiver is made, the mother, father, daughter, really sort of thinking about those relationships, making sure that the caregivers are giving to themselves and having support and being told that it's okay to think about themselves sometimes. And I've even said to some of my patients, with their caregivers, to model, to just sort of give voice to what that struggle is, right? And how illness changes all the relationships and the dynamics. So seeking not only counseling and groups separately, but I often find seeking counseling and groups together to figure out how are we going to reform this relationship so I can still provide care, but I'm still your mom, your dad, your husband, your wife, your child.
Thank you.
Thank you. This is an advocacy question. How do we make it a requirement for medical boards to have requirements to include patients as members or directors?
Okay, this is going to sound hokey, but you got to call your representative. And you got to show up at the Capitol Day. And you don't think it makes a difference, but votes make a difference. They believe whatever their constituents say. And sometimes when you elevate it, or you can put a personal story. Like I can go and say, hey, this should be. And they're like, there, Dr. Leedy. Let's take a picture. But when there's always a picture. Like they can shut you down, and then they're like, let's take a picture. Take a picture with you. You just told me no. No, but when you come and you say, right? And you come, but you don't come one time. You come 2 times, you come 3 times. You make those phone calls, you talk to those aides. You have your fact sheet. They have a attention span of a gnat, so just make it like 5. Make it real easy. But that's what it takes. It takes these kinds of concerted efforts and people like this in the room en masse. It can happen. Cruise ships do turn, but it does take a lot of force and it takes a lot of time. Right. I wish I had an easier answer.
This question is about alcohol use. We are now told that alcohol causes breast cancer. What about having an occasional glass of wine?
So this is hard. So I have to choose my words very carefully. I say it depends on how you are going to feel if something happens. Can you live with it? So I have some people who, may have a glass of wine, and then a few years later, they may have progression, but they don't link the two. Like they're able to kind of compartmentalize. I have some have that glass of wine, and they're going to link that. And knowing how, and understanding kind of how they process, that guilt is going to start to consume. So I'm pretty sure, or I think, that occasionally a sip here or there, if you really need to have it for your quality of life, is fine. But if that voice inside you, if it's not coming from you and it's coming from your friend saying, just take the, just do it, and you know how you process things, then I would say not, because if something else happens, it will be difficult to live with. And the last thing you need is one more thing to feel guilty about.
Thank you. Dr. Curseen, I'd like to ask you to leave us with a few words of how we can feel confident.
Oh, a few words, how do you feel confident?
Yeah, boost our confidence and our certainty and our security from your slides.
Okay, wow. Okay. So to boost your confidence, you're here. You're here right now. You're here today. And all the things that you have worked for have not gone away. And the chemo fog, don't worry, they're going to come back. It's just like a 30-second delay. It's just a delay. It's there. It's there. But all of those accomplishments, all the things, whether you mom, job, none of that has disappeared. It's still there. It's still there. And, the other thing, too, is humans are amazing, and we figure out how to live with things. We do. And we figure out how to live with very, very little. We see it all the time. Humans are amazing. And each person in this room takes up space in this world that is important. Just because you're here, right? And you're part of the fabric, I believe, of a larger whole of everybody else that you touch. So when you walk out the room today, number one, I'm going to walk out, and I'm here for right now, and in this moment, I am fine. One day I won't be, but today I'm okay.